Hi, so my name's Dr. Deborah Sarnoff, and I'm a dermatologist and a Mohs surgeon specializing in skin cancer. I'm president of the Skin Cancer Foundation, a nonprofit based in New York that's a national organization. And I'm also a professor, clinical professor of dermatology at NYU, Grossman School of Medicine. And I'm happy to be here today to talk to you about actinic keratosis. So actinic keratoses are very, very common. We certainly see them a lot in patients over 50 because we do feel that the sun definitely is responsible for a lot of the changes in the skin that cause the actinic keratoses to come about. Uh, they're usually described as rough, scaly. You can feel them sometimes better than you can see them. I tell patients they sometimes give the skin a texture like sandpaper, or almost they feel like little Rice Krispies on the skin. And sometimes they're pink, but sometimes they're beige or tan, and sometimes they could even be pigmented. Uh, we see them more commonly on the scalp, especially of bald men. We see them on the tops of the ears or the edges of the ears. We see them anywhere really on the face. On the lower lip, we sometimes see areas that just don't seem to be normal lip. So sometimes uh, we think about biopsying them more if they're painful or tender, if they're bleeding, if they're crusting, so there's a sign that maybe they were previously bleeding, if the patient tells you that they've grown quickly and they have elevated where they previously were not that high off the skin, or if you palpate even through gloves and you feel like the skin is a little bit what we would call indurated or harder, or you feel like there's a thickness to it, or maybe there's one outlier. Maybe you have a whole area of actinic damage and you have a bunch of these little keratoses, but one of them looks more inflamed, or it just looks larger or just different to the naked eye. That's usually would be an indication to biopsy. So a lot of people don't put two and two together. I've had patients that are severely sun damaged, but they tell me they never go in the sun. They never sit in the sun. And, I'll often show them the skin on their breast or on the buttocks and show them skin that's been protected all these years with two layers of clothing versus the skin on the décolletage of women who wear the shirts open very often. Or I'll show them the inner aspect of the arm versus their forearm that's outside, and explain to them that really it's a manifestation of sun damage that we get these changes in the skin. And I try to really inform them that they're coming from not only the sun that they had from years back, but there are things that they can do proactively to diminish the chance of developing skin cancer. And I try to explain to them it's a sign of sun damage. And in some cases, the actual actinic keratosis might develop into a squamous cell. In other cases, it's just telling us that that area is vulnerable, it's been damaged from the sun, and you need to protect. And when it's on the scalp, well, a hat is probably the best way to protect because, especially if you have a wide brim, like maybe 3 inches all around, it gives really good coverage of the scalp and it'll also shade the face. So it's really important to make patients understand what the actinic keratoses are coming from and what they might do about it going forward.